Today's topic is bilirubin metabolism and unconjugated hyperbilirubinemia. Coming to bilirubin metabolism first. RBC breakdown and cytochrome P450, their breakdown leads to formation of globin and heme. This heme is acted upon by heme oxygenase and is converted to biliverdin. Another enzyme, biliverdin reductase, acts upon biliverdin and is converted to unconjugated bilirubin. This unconjugated bilirubin is fat soluble and it enters hepatocytes via facilitated diffusion. And in hepatocytes, it is acted upon by glucuronide transferase and is converted to conjugated bilirubin. This conjugated bilirubin is water soluble and it is excreted into bile via MRP2. This bile is stored in gallbladder and it goes to intestines. The intestines it is either excreted via feces in the form of stercobilin or it is acted upon by bacteria and is deconjugated and it goes to blood circulation in the form of urobilinogen. From the blood circulation, it goes to kidneys and is either excreted in the form of urobilin or it goes to enterohepatic circulation. And it goes back to hepatocytes and is conjugated inside the hepatocytes. And it should be noted unconjugated bilirubin, it enters hepatocytes via facilitated diffusion, which I have already mentioned. Inside the hepatocytes, it is bound to plasma proteins like ligandin, and when it is attached to ligandin, it reaches endoplasmic reticulum. This unconjugated bilirubin has two propionyl side chains, and these side chains are actually sites of glucuronidation. This conjugated bilirubin is thereby transported by MRP2 and BCRP1. Now coming to unconjugated hyperbilirubinemia. In hereditary unconjugated hyperbilirubinemia, we have three types. One is Crigler-Najjar syndrome type 1, Crigler-Najjar syndrome type 2, and Gilbert syndrome. In all these, there's a defect in the enzyme which is responsible for glucuronidation or conjugation. Enzyme activity in Crigler-Najjar syndrome type 1 is 0%, while as in type 2 it is less than 10% and in Gilbert syndrome it is less than 30%. And liver function tests will be normal in all the three types, that is Crigler-Najjar type 1, type 2 and Gilbert syndrome. In Crigler-Najjar syndrome type 1, bilirubin is around 20 to 50 mg per deciliter, while as in Crigler-Najjar syndrome type 2, it is around 7 to 20 mg per deciliter. In Gilbert syndrome, it is less than 5 mg per deciliter. Now coming to bile pigments in all these types. In Crigler Najjar type 1, there are traces of bilirubin glucuronides in bile, while as in Crigler Najjar type 2, the bilirubin conjugates will be much decreased, while as in Gilbert syndrome, it will be decreased to 30% of normal. Phenobarbital is an enzyme inducer. It has no role in type 1 because there is no enzyme activity, while as it decreases bilirubin by greater than 25% in type 2, and it causes normalization of bilirubin in Gilbert syndrome. The inheritance is autosomal recessive in all the three types. Now coming to molecular basis. In type 1, the genetic lesion is in the coding region or splice site of UGT1A1. While as in type 2, there is a point mutation in coding region. In Gilbert syndrome, there is insertion of TA dinucleotide within TATA element of UGT1A1 gene. The prevalence of Crigler-Najjar type 1 and type 2 is very rare. It is less than 1 is to 10 lakh, while as it is around 4%. It is very common in Gilbert syndrome. Kernicterus is very common in type 1, while as Kernicterus is uncommon in type 2. In Gilbert syndrome, prognosis is very good, except there may be toxicity of some drugs. Now coming to TATA box or Tata box in Gilbert syndrome. What is the significance of Tata box in Gilbert syndrome? We have a protein that is called Tata binding protein. It binds to Tata sequence of UGT1A1 gene, which is a promoter of transcription. The normal motif of this gene is TA multiple times. It is around TA 5 to 8 times normally, then TAA. Normally we have 5 to 8 dinucleotides in this sequence. In Gilbert syndrome, there is homozygous polymorphism. The TA dinucleotide may be increased in this sequence. And by increasing this TA dinucleotide, there is decreasing Tata binding protein binding capacity. As a result, there is decrease in enzyme activity. Only one TA dinucleotide decreases enzyme activity by 70 to 80%. Now coming to the clinical features of unconjugated hyperbilirubinemia. When there is increased unconjugated bilirubin, it exceeds albumin binding capacity. As a result, the free bilirubin concentration will increase. As I have already mentioned, the unconjugated bilirubin is fat soluble, so it will accumulate in lipophilic tissues like brain. So after getting accumulated in lipophilic tissues, there is oxidative stress and mitochondrial metabolic damage, thereby causing neurological damage. Initially, the damage is mild and reversible, and in the initial stage, the patient may be having hypotonia, lethargy, anorexia, and abnormal auditory brainstem evoked potentials. In the later stages, the neurological damage may be severe. There may be involvement of gait. The patient may be having abnormal gait and imbalance. There is impaired fine motor skills and ataxia. Because now the bilirubin is deposited in basal ganglia and cerebellum. When the unconjugated bilirubin concentration further increases, there is more severe damage, which is irreversible, and the condition is called kernicterus. In this damage, there may be cerebral palsy. The patient may be having high frequency central neural hearing loss and dental enamel hypoplasia. Now, coming to the management of unconjugated hyperbilirubinemia. Before discussing the management and newer therapies in the management of unconjugated hyperbilirubinemia, I want to point out two important things here. One is about phototherapy and second is about liver transplantation. In the process of phototherapy, unconjugated bilirubin is converted to photoisomers which are water soluble and are thus excreted in urine. That's why phototherapy is beneficial. So, what is the role of phototherapy in all the three types of hereditary unconjugated hyperbilirubinemia? In Gilbert syndrome, there is no role of phototherapy. In type 2, there is a role of limited phototherapy plus phenobarbital, while as in type 1, intensive phototherapy is needed around 10 to 12 hours per day. And liver transplantation may be required in type 2 Crigler-Najjar syndrome, while as it is not required in Gilbert syndrome. In type 2 Crigler-Najjar syndrome, it may be required according to severity. In the newer therapies of Crigler-Najjar syndrome, we have heme oxygenase inhibitors, biliverdin reductase inhibitors, phototherapy, as I have already mentioned it. With phototherapy, unconjugated bilirubin is converted to photoisomers which are water soluble and are thus excreted in urine. Phenobarbital is an enzyme inducer. It actually induces UGT1A1 activity. And there is a role of ursodiol calcium phosphate. This decreases unconjugated bilirubin absorption in intestines. Albumin infusion has also a role. Albumin, it decreases free bilirubin because unconjugated bilirubin is bound to albumin in the blood circulation. Now, there is a role of anti-inflammatory and neuroprotective drugs in preventing chronic tears. In the end, orthotopic liver transplantation, cell therapy, that is hepatocyte transplantation, and gene editing therapies has a role in unconjugated hyperbilirubinemia.